Good day to everybody. Many thanks for making the time to watch this video. My name is Shams Al-Hassani. I am consultant in upper gastrointestinal surgery, specialized in weight loss bariatric surgery. I would like to share with you a recent experience. I attended a meeting in Ho Chi Minh in Vietnam regarding bariatric surgery. One aspect of the meeting was discussion of revisional surgery. Revisional surgery means that patients who have a primary bariatric surgery, whether it is a sleeve, band, or a gastric bypass, years later they will need revisional surgery, need revising the surgery. And this is usually due to insufficient weight loss or weight regain, or have a type of complications. And in this video, I will limit the talk on sleeve gastrectomy because something that is commonly performed nowadays. And the sleeve gastrectomy is a good operation, in fact, very good operation, when it's used in its own indication. The reason I say this, that for all bariatric surgical procedure, each one of them does something that the other doesn't do. So when the sleeve gastrectomy is used in its corrective indication, the results are very good. However, like other bariatric procedures, the long term there may be problems. And in the sleeve, the common problems that can happen is reflux, weight regain, or both. With the reflux, patients will come and tell us that symptoms of indigestion started gradual and increase in frequency. These are heartburn, regurgitation of food after eating, choking at night, chest pain, pain in the upper part of the abdomen, all these symptoms of the reflux. The weight regain is self-evident, where you lose the weight and years later you start putting the weight back again. Or sometimes patients present with both symptoms, the weight regain and the reflux. So of course these become disheartening for patients, come to us asking advice. And the surgical pathway will need investigation, where we will do a camera called a gastroscopy, looking inside the gullet or the esophagus, inside the sleeve, taking biopsy, see the level of inflammation, and also a barium X-ray, which will give us more idea about the anatomy of the sleeve, the relation of the sleeve to the diaphragm and the esophagus or the gullet. Sometimes we need a CT scan as well. With this information in hand, with the patient's symptoms, we can then design the surgical procedure. The revisional surgery, revising the surgery, will be keyhole surgery again, where we dissect the sleeve, meaning we release the sleeve from all the adhesions available, and we calibrate the sleeve again to make it a tighter sleeve. So if the sleeve has dilated, we trim it and make it tight so it starts working. And dissecting the hiatus means if there's a hiatus hernia, we need to dissect it, reduce it, and close it. And usually conversion of the sleeve into a gastric bypass, whether it is the old Roux-en-Y gastric bypass or the new version, the mini-1 anastomosis gastric bypass, depends on a variety of factors, patient symptoms, and the result of the investigation. Less frequently is only re-sleeve the sleeve just to make the sleeve tighter, and that's it. And the options will be discussed with you in advance before the operation. In that meeting, I presented my results of the patient I reversed from sleeve into a bypass, and it is really encouraging. The 5 results are very good, not in only my hand, in the hand of my colleagues as well. So the message, if you have a sleeve gastrectomy years before and now you have a problem, then please do not despair, because there is a surgical solution, and the long-term result of this surgical solution is fantastic. So thank you for listening.